Sir? Sure. No problem. No problem. Yeah, that's fine. Okay. Um, we thank you very much for Professor Wasim Hanif, Professor Rakesh Sahai, Dr. Sudhakar Rao, Dr. Vishnupriya Rao for joining us and chairing the session today. Idea Clinics, as you are aware, is mainly focuses on preventive health care, and there's mainly focusing on diabetes and other communicable diseases. So Idea Clinics, as you are aware, has pioneered a predictive model of healthcare, mainly promoting the healthcare with human touch and combined with the technology. With hybrid omnichannel platforms and cutting-edge technology, is integrating healthcare with a vision to reduce burden of these preventive conditions. And Idea Clinics is positioning itself with a unique model in healthcare outside the hospitals across India. And we are trying to achieve right balance of technology with process automation supported by human interfaces from specialist doctors. We have several verticals that includes main Idea Clinics supported by Idea Pharmacy, Idea Skills, and Idea Health Tech. We are trying to pioneer into the latest technological advances that will help better application of healthcare in patients, especially with metabolic diseases such as diabetes, obesity, and among others. Yeah. With this, I welcome Professor Wasim Hanif, and we thank you very much for joining our session today. As we know, he's a professor in diabetes and endocrinology and consultant physician and head of services of diabetes at University Hospital Birmingham. He's also honorary professor of medicine at University of Warwick. Yeah. Yeah. He is involved in several international projects that include IDF, Strategy for Commonwealth to guide ministers at UN Summit, Chair International Advisory Board of On-Aid Project of MRC UK, Foreign and Commonwealth Scientific Trade Delegate and Committee to India. He's involved in board member. Sorry. He's a board member of Center for Diabetes and Endocrine Metabolism, University of Birmingham, and Clinical Advisory Group, lead for research in diabetes and endocrinology at Institute of Translation Medicine, Birmingham. His research includes several topics, including diabetes kidney disease, diabetes prevention, diabetes and cardiovascular disease, and management of diabetes and Ramadan obesity, and tackling health inequalities. His well-known authority is on real-world evidence, working on big data with dedicated bioinformatics team. Welcome, sir. I now introduce Professor Rakesh Sahai to join us. Yeah. We welcome Dr. Sudhakar Rao to join us as a chairperson today. Please come to the dais, sir. As we know, Dr. Sudhakar Rao has an experience of 33 years in the field of endocrinology. Did in endocrinology in Postgraduate Institute of Medical Research in 1984. He is a member of IMA. His area of expertise include diabetes management, thyroid management, bioidentical hormone therapies for men and women, and goiter treatment. Thank you very much, sir, for joining us today. Now I welcome Dr. Vishnupriya Rao Paturi to the podium. Dr. P.V. Rao is the so please come in, sir. He is the co-founder and director of Diabetomimics Operation in India and Asia. He was previously professor and chief of endocrinology at Nizam Institute of Medical Sciences, and Dr. P.V. Rao established the Research Society for the Study of Diabetes in India, RSSDI, and served as secretary from 1993 to 2007. A warm welcome, sir. Thank you. With this, we will move on. Sir, you would like to join us, sir? And I say, thank you very much, sir. So we warmly welcome Professor Rakesh Sahai for chairing this session today. As we know, he is Joint Secretary of RSSDI, AIRO, former Secretary, Endocrine Society of India, Founder Secretary, South Asian Federation of Endocrine Societies, former Chairman of the AP chapter of RSSDI and Hyderabad chapter of API. He is also Associate Editor of Indian Journal of Endocrinology and Metabolism, Fellowship of the American College of Endocrinology in 2009, and Fellowship of RSSDI in 2015. He is also Fellowship of Indian College of Physicians in 2006 and Fellowship of Indian Academy of Clinical Medicine in 2008. He has over 100 publications in various national and international journals. A very warm welcome, sir. With this, we'll move forward to our talks today. I invite Professor Wasim Hanif to give his talk on the practical review of C-peptide testing in diabetes. Yeah. Thank you, sir.
Just oh. Yeah. Good evening. Can you hear me? Good evening, everyone. I would like to take this opportunity, first of all, thank Shyam Kalvapalli. We were colleagues in UK, for his kind invite. Whenever I come to Hyderabad, Shyam always gets me a chance to speak. So thank you very much, and thank you very much, Rakesh. We've been together in Nizams, and it's my great honor that I'm actually speaking before what I would call my guru of diabetes, Professor P.V. Rao. I and Rakesh were his students. So, namaskaram, sir. It's a great honor and privilege that you are the chair where I'm speaking. I learned about diabetes my initial days from you. So today, when Shyam actually suggested what we should be talking about, I was thinking about a lot of topics, but this is an area that has particularly interested me. We have done a lot of work, and today in my talk I would like to kind of acknowledge two people who worked with me closely. One is Dr. Shrikant Bellary. I think he was Rakesh's classmate from Osmania, who is now one of our colleagues and senior lecturer in Birmingham. He has done some of his work, and the other one is Dr. Shivani Mishra. She's also a young, upcoming senior lecturer at Imperial. So some of the work that I'm presenting today has been done by them. The reason the C-peptide and insulin have actually started fascinating a lot of people was, I remember a conversation I had when I was training in Birmingham with Professor Mike Shepherd. Professor Mike Shepherd is considered to be a doyen of endocrinology internationally. And I asked Professor Shepherd, I said to him, you know, somehow when you come to the endocrinologist and diabetologist, why do the endocrinologists have a bit of an attitude and always think diabetologists to be a bit lower? Because my interest was in diabetes. And he was if you have met Mike Shepherd, he's quite a exuberant South African person. And he said, diabetologists, how can they be endocrinologists? Because they don't measure their hormones. And he was absolutely right. As diabetologists, we don't measure insulin and C-peptide. And he said they are the only endocrinologists who don't measure their own hormones, be it thyroid specialist, be it adrenal specialist. Everybody measures their hormone. And we've always relied on a surrogate marker of glucose to try and treat diabetes. The second big issue that has happened, and this is something which is very important, is that a lot of work and research, mostly led by the industry, has gone into the treatment of diabetes. So which technically means that all diabetes we have classified into type 1, type 2, and basically we start giving them medications. We really don't spend time to really diagnose what is the type of diabetes, and a lot of work has not been done in terms of establishing a diagnosis of diabetes. Just a glucose of more than 120, or what we say more than 7, classifies as you have diabetes. And over a number of years, we have started feeling that the patients we picked up as type 2 diabetes turned out to be something else. So as we all know, this is the 100th year of insulin discovery. Insulin was a fascinating discovery, and you know, we still owe it to these 4 people for giving us insulin that really transformed the care of people with diabetes. As I said to you, this has been a therapeutic development. And since the development of diabetes, we have seen a plethora of medications coming in, starting from the animal insulins to the GLP-1 analogs to GLP, GIP combinations, and they have all been used in terms of treating diabetes. And this is great news for our patients. But when it comes to establishing diabetes and looking at the diagnosing diabetes, there's not been much in terms of development. And today I'm going to go and take you back to the basics, talking about the basics of diabetes and discussing a couple of our cases. So let's go back to the basics. So basically, diabetes, as we know, has got 2 big components to it. One is it monogenic and polygenic? Monogenic diabetes is what we now call MODY. And you're born with it and always going to develop diabetes. A lot of work on MODY diabetes was done by Andrew Hattersley, who was my colleague. We trained together in Birmingham, and now he's considered to be a world authority. Most of the research on MODY comes from him, from Exeter. When I actually was working with Andrew Hattersley, so we were both research fellows for Tony Barnett. So he gave him the monogenic diabetes, and he named the name, and he gave me polygenic diabetes research, which is type 2 diabetes. I was very excited about it, but now, 15, 20 years down the line, I think I've wasted my life because nothing came out of it, and I'll tell you why. So polygenic diabetes is a polymorphism which increases the risk of diabetes, and you're not born with it, but high risk, and may develop later depending on other factors. And the other factors is it genetics or environment is always a big question. Is it the lifestyle that causes diabetes, or is it the genetics? And this you're talking about type 2. The way I look at now after all this work is, you know, you can have a low genetic risk, but if you've got strong environmental factors, as we are seeing in certain Western populations in which, because of a Western lifestyle, very, very little physical activity, a lot of obesity, we are seeing it. We see a lot of it in the United States. Second is the high genetic risk plus weak environmental factors. This is something we tend to see mostly in a South Indian context. A lot of work done by Professor Mohan looks at people who are not really big, who are not obese, and they still tend to develop diabetes. And then we have got this high genetic risk plus strong environmental factors. We see it in Arab countries, in the Middle East, where you're talking about prevalence rates of nearly 50 to 60%, where there is a high genetic risk plus strong environmental factors, which is driving type 2 diabetes. And then we have got the low genetic risk plus weak environmental factors. This we see in the higher echelons of the society in the West, what we call the royal family kind of thing, where hardly there is any diabetes. They don't have any risk factors. They have got a very healthy lifestyle. Everybody is biking and hardly eating anything, or eating a very low-carb diet, and the prevalence of diabetes is low. So this is the whole spectrum of what we call the interaction between genetics or polygenic involvement along with environment. So what happens when we look at type 2 diabetes in genetics? So this is the part of what we call the GWAS, the Genome-Wide Association studies. In the initial bit of my career, we did a lot of things to try and identify any genes that would cause an increased risk of type 2 diabetes in a South Asian cohort. And we had comparisons between the white population and the South Asian population. And this was some of the work we did with Jaspal Kuna. We published in Nature. And this is what we found, that people with type 2 diabetes and people without type 2 diabetes, there are nucleotide changes present in type 2 diabetes groups, but not controls. But it is very difficult to assess effect size. And it is not the ethnicity that actually drives this nucleotide change. And if you are into genetics, if you want to really understand this, because I worked with a lot of scientists, what you will find is that there will be a lot of established locus, novel locus, additional distinct signal. But if you actually look at the effect size, it is quite a wide distribution, and it's very difficult to identify whether a particular nucleotide or chain is actually driving it. There might be better work, better genetic techniques which will help to identify it, but currently it is quite a big challenge. The monogenic diabetes is much more simpler because these are single gene mutations and you can actually identify it. The one that has been studied the most and is probably the best is MODY, which is the maturity onset diabetes of the young, which is a single gene defect causing diabetes. And then we have got neonatal diabetes, which is diabetes diagnosed less than 6 months of age, again linked to genetics. And they are the mitochondrial diabetes, which is diabetes and deafness or other mitochondrial syndromes. Now let us look at MODY, and especially look at MODY in the South Asian context, and this is some of the work of Shivani and Shri. Now, MODY actually accounts for only 2 to 4% of diabetes diagnosed less than 30 years, and this is in all populations. Most of the cases are missing because they're classified as type 2 diabetes and are not picked up. There are lots of benefits of identification of MODY because then you can target the treatment depending on affected gene and do effective genetic counseling. And then you can do cascade testing in the families. And then there is prediction and screening of multi-system features. If you look at the prevalence of MODY, and this is the My Diabetes study from Exeter, and what it actually shows is that the pickup rates in the white British population is about 29% when you do molecular genetic testing. In the South Asian population, the pickup rate is only 12%. And this is highly statistically significant. So this implies two things. One is either the prevalence of MODY is very less in a South Asian population, or more importantly, the young onset of type 2 diabetes, which we're going to be talking about, there is a high prevalence of young onset type 2 diabetes in a South Asian population because of double gene dose effect coming from both parents having diabetes and other factors. And therefore, the prevalence rate appears to be low. And this is something that is being looked at. You must all be aware of these mutations. Every time you look up, there's a new paper from Exeter identifying a new mutation for MODY, but these are probably the most identified mutations. And it's very important to identify a specific mutations because the treatment of it actually differs. So if you look at HNF1 alpha and 4 alpha mutations, which are quite common, these can be treated by low-dose once-daily sulfonylureas. Glucokinase mutations do not require any treatment. Most of the time, the blood glucose levels are slightly elevated, and the complications of diabetes do not occur in this group of patients. The beta cell transcription factor mutations, these require insulin and perhaps even pancreatic enzyme replacement. And this, they behave more aggressively, more like type 1 diabetes in terms of their complications. And then you have got the ATP-sensitive beta cell potassium channel mutations. These need treatment with high-dose sulfonylureas, usually three times a day. So therefore, it's not only important to identify MODY, but it's important to identify the type of MODY by which you can actually direct the treatment. This is where the whole concept of precision medicine is developing. Now, before we start talking about C-peptide, let's look at the other genetic characteristics of diabetes, especially in young. This is more of a pediatric area, but again, it's very important for us to do it. You must have all heard about it. This is more common in pediatrics, about neonatal diabetes mellitus. This can either be transient or it can be permanent. NDM is antibody negative. It's insulin sensitive hyperglycemia during the first 6 months of life. Type 1 diabetes does not develop in the first 6 months of life. So if a baby has diabetes at birth, it is usually neonatal diabetes mellitus. 10% of the patients have got syndromes like the pancreatic aplasia, and the various genetic possibilities identified and various genetic mutations are there. The commonest is in the sulfonylurea receptor. MODY, as I said to you, it's characterized by, if it's HNF1 alpha, it's glycosuria, and if it's glucokinase gestation, it's more like gestational diabetes. So when do we suspect MODY, and what are the criteria for actually testing patients for MODY? The first one is the onset should be less than 25 years. Most of the patients with MODY would present before 25 years. There should be an autosomal dominant pattern of inheritance, which means only one parent should be involved in having the diabetes. If both parents are involved, it is very unlikely that it is MODY, and this is where, in a South Asian and an Indian context, where things get wrong. So it is an autosomal dominant inheritance. It is usually can be controlled without insulin. This is to differentiate it from type 1 diabetes for the first 5 years. And depending upon the mutation, insulin may be required later. It's an autoimmune response to beta cells, leads to decreased insulin secretion. And I have mentioned the most common gene codes involved. And some of them can be required, like glucokinase require no treatment, while the HNF1 alpha and 4 alpha require sulfonylureas, while the potassium ATPase mutations require insulin. So in terms of implementing personalized care for MODY, it is important to identify if it's HNF1 alpha, 4 alpha, 1 beta respond to low-dose sulfonylureas, and 1 beta requires insulin for treatment. Glucokinase does not require any treatment. Then there is all this condition called congenital hyperinsulinemic hypoglycemia. In this, the hypoglycemia develops just after birth in first few months of life. And hypoglycemia could be severe, debilitating and persistent, and there are definitive mutations. Some patients respond to digoxin, but some may require subtotal pancreatectomy. There is a megaloblastic anemia which responds well to thiamine, and they can develop monogenic autoimmune syndromes. So this was just an overview of the various genetic types of diabetes that are there. Now today I'm going to focus on what we call young onset type 2 diabetes and type 1 diabetes, and what are the current challenges of identifying these patients correctly and trying to treat them. So when you look at the young onset type 2 diabetes, this is defined as under 30 years, in some cases under 45 years. The prevalence rate is rising across the globe, especially in the UK and the US, in the minority communities, mostly South Asians and African Caribbeans. There is a faster progression to insulin compared to older onset type 2 diabetes. And now there is a lot of data coming in, especially both from the US and the UK, and there's a recent publication from a group showing that these patients have got worse clinical outcomes when compared to people with type 1 diabetes. So young onset type 2 diabetes patients actually do much worse than type 1 diabetes patients. And it's disproportionately affecting the people of the South Asian ethnicity. And this is quite a big challenge as to how we identify and treat them correctly. So therefore, we need a correct diagnosing tool at the time of diagnosis. Now let's take an example of a 29-year-old man, and we are seeing a number of these patients. I'm sure you are seeing it in your practice, who comes with a glucose of 18. So I'm using, sorry, this is a UK presentation, so it's got the UK units always multiply by 18, complaining of osmotic symptoms. The question is whether the patient has got type 1 diabetes. Then they will require insulin injection, insulin pump, self-monitoring, education, carbohydrate, quantity, extra, along with legal implications. It's type 2 diabetes, where you have to talk about lifestyle, tablets, and does not require routine glucose testing. Or it could be another type of diabetes, be it MODY, be it type 3C, and this may require insulin tablets or nothing. I'm going to use an example of one of my patients who actually presented in our clinic and try and take you through this patient's journey and try to explain about things a bit more clearly. This was a 19-year-old female in college of Bangladeshi ethnicity. Her BMI was 23, which means she was not very obese. She complained of 2 weeks of tiredness, polyuria, and thirst. Mother has type 2 diabetes and is on insulin. Mother checked the capillary blood glucose at home, and it was 18. The first question we need to ask ourselves, what blood test might help to classify her diabetes, whether it's type 1 or type 2? We can do the ketone testing, but that doesn't really help. And this is where the whole story of the C-peptide and the focus on C-peptide comes back. So let us go back and revisit about what is C-peptide. So we know that the pancreas actually secretes insulin in a proinsulin form. And just before the release, the insulin is cleaved and the C-peptide is released. The reason why proinsulin, the pancreas stores insulin in a proinsulin form is to prevent hypoglycemia. So it's a cleavage product of proinsulin. The advantages of C-peptide when compared to insulin measurement is, insulin, the moment it's secreted, it actually goes in intracellularly and it's very unstable. If you speak to any biochemist, they will tell you the insulin assays are very noisy and very difficult to measure. When compared to it, the C-peptide has a longer half-life, it's more stable than insulin, and it does not have a first-pass metabolism, so it can actually last longer. And now it is considered to be an established marker of beta cell function. Along with it, we have got pancreatic autoantibodies. The pancreatic antibodies that we have is the GAD antibodies or GAD65, islet antigen or IA2, and zinc transporter 8. These are the three we tend to measure. We are no longer measuring what used to be called as the islet cell antibody. These are primarily studied in research setting to predict the onset of type 1 diabetes. The role in the classification of diabetes is unclear, and I'll explain why. One of the caveats that we have to do when we are interpreting the antibodies is the first thing, antibody negative does not exclude type 1 diabetes. It's less than complete testing, and people from some ethnicity, and this is again our work in a South Asian context showing, have lower rates of positivity, and titers diminish over a period of time. So what is the best practice for testing antibodies? The first question you have to ask yourself is, what's the clinical question? antibodies should only be measured to support a diagnosis of type 1 diabetes and not otherwise. And then again, we all need to remember type 1 diabetes is not excluded if the antibodies are negative. So if the clinical suspicion of type 1 diabetes is high, then do not defer insulin. Please start insulin immediately. If the clinical suspicion is low, we need to be clear as to why we are measuring the antibodies, and we need to have a clear question in mind. If the clinical suspicion is intermediate and antibodies are positive, these are supportive of type 1 diabetes diagnosis. Now we come to C-peptide. The first question we have to ask ourselves is, what is normal C-peptide? And I'm going to go through some of the algorithms that have been developed. The challenge of C-peptide is that the no normal ranges have yet been defined. It's not robustly evaluated cutoff that delineates one type from the other, although there have been some suggestions which I'm going to go through today. And it's not interpretable at the time of diagnosis. If anything, it causes a bit of confusion. So now coming back to my case, the question is, what treatment should she be started on? The first question is, we don't want to miss the type 1 diabetes and delay insulin while waiting specialist test. She's young, she's not overweight, she's UK born to Asian people, appear to have similar risk of type 1 diabetes. And sometimes diabetes classification takes time beyond the results of immediate specialist test. And I would like to hear from Professor Rao about how we can get this much quicker. So this patient was started on a type 1 diabetes regime with Levemir, BD insulin, and Novarapids. 3 weeks later, we got the antibodies, which were negative for GAD65, IA2, and ZNT8. The question is, would you evaluate your diagnosis now? It is possible that this patient has got antibody negative type 1 and needs to see how it evolves, and C-peptide will help further down the line. This could be monogenic diabetes if the family is compelling and could proceed to genetic testing, or is it early onset of type 2 diabetes? So the question really is, and this is where we are going to do, is how we stratify diabetes currently. So if there is a new presentation of hyperglycemia, especially in a young person, less than 30 years or less than 25 years, the first question we have to ask ourselves, is this MODY? And we need to have a clinical suspicion of MODY. And if the patient fits the criteria for MODY, we should try and do the genetic testing. The second question is whether the patient has got type 1 diabetes, especially if the patient doesn't present with diabetic ketoacidosis and you're thinking about diagnosis. This is where the testing for the GAD, IA2, and zinc transporter antibodies becomes important. At the same time, looking for C-peptide to give us some idea about the diagnosis. The third is whether this is pancreatic type 3C diabetes. Now, this is something that the world has suddenly woken up to. When I was actually training in India about 25 years ago, there was the whole concept of the malnutrition-related diabetes, and there was a lot of push to have malnutrition-related diabetes in the WHO and the idea of classification, but it was rejected, as most people thought that this was not happening. But pancreatic type 3C is revisiting the malnutrition-related diabetes, because this involves anything that involves the pancreas. So things like pancreatitis, things like exocrine dysfunction of the pancreas, and in some people, and these are the reports coming mostly from Africa now, where you're seeing this, and the treatment of pancreatic type 3C is turning out to be different. And if we are able to exclude all these things, especially in young patients, then we proceed to type 2 diabetes. So currently, type 2 diabetes is the diagnosis of exclusion. So what we really need to look at, and this is one of the things that we have to really change, is in a young person, the moment they come with blood glucose, sending them home with metformin is not the option. One of the things that we are trying to do in the UK and perhaps across globally is in young people, type 2 or diabetes should be diagnosed by a specialist, a diabetologist, and endocrinologist, and not by the family physician. Because in a family physician, and there could be loads of cases, there's one example I've given, the concept is that if you're not in decay, so they check your blood glucose levels, it may be 25, they dip your urine, there is no ketones, and you're classified as type 2 diabetes, and all these diagnoses are missed. And therefore, it's very important for us to all realize that diabetes, especially in young, can be many, many things than type 2 diabetes. So this is where I use the concept of buckets. So who's in the type 2 diabetes bucket? So who's in the type 2 diabetes buckets? So along with people with type 2 diabetes, they are the genetic and type 1 diabetes who were not ketotic at the time of presentation. So these are the ones that have been misdiagnosed with other types of diabetes. These are the ones what I call the bona fide type 2 diabetes, where we don't have to do anything. And this is where all the research of type 2 diabetes and the guidelines of type 2 diabetes have come from. So usually these are white Europeans who are overweight or obese. They are middle-aged or older at the onset. And if you look at ethnic minority groups, usually South Asians, they're much more. So these are bona fide type 2 diabetes you don't have to be worried about. Then there is this whole concept of atypical type 2 diabetes. So the people who are different in some ways, but don't have other types of diabetes. So this could be thin diabetes, this could be type 3C diabetes. These are all put in the same bucket. And therefore, it's very important to identify. So when we talk about atypical type 2 diabetes, what are we talking about? So type 2 diabetes does not fit the expected mold. But the important thing is, the mold has been defined on historical features, predominantly in white European population. And this is something which I'm very, very passionate about. All the guidelines that we have got, when we say SGLT2 inhibitors are the first line, or the GLP-1 analogs should be given to everybody who has got a blood glucose level going slightly up. If you look at the studies, this was an analysis I and Professor Kamlesh Kunti did. And we put all the cardiovascular outcome trials that have founded the guidelines. And these are the guidelines that are talked about across the globe, including in India. And if you look at the number of Indian population in it, it's hardly less than 5%. In some trials, there is no Indian or even Asian populations. So these are white European trials. So why are these different? So one of the things when you raise it with the regulators in the UK and even in the US, they say all humans are the same. So what is the difference? Now, the example I give to them is the DIRECT study. So this was done by a very good friend, Roy Taylor. I was in the Diabetes UK research committee that gave them £5 million to do DIRECT study. And DIRECT study was very simple. You give the patients 800 kilocalorie diets, make them lose 10 to 15 kilograms in weight, BMI 45, in 85% of the patients, diabetes disappear, and this is called diabetes remission. And this was propagated globally. There have been a number of conferences in India. I've seen speakers, excellent speakers, both from India. Roy Taylor has been here several times, talked about DIRECT study. And I said, and I challenged Roy Taylor and basically told him, if I've got an Asian patient, which I've got lots in Birmingham, and if his BMI is 25, how much weight do you want him to lose? He's going to disappear. But what was interesting was there was the National Diabetes Audit, so now the DIRECT study has been implemented across the UK as a part of the NHS Diabetes Remission Program. When they did that, in the original DIRECT study, 99.9% of the population was white European suburban. When they implemented and measured it after 2 years, this is again published in Lancet Diabetes Endocrinology by Jonathan Vallabhji, what it actually showed was the acceptance rate was only 10%. And in the Asian population of the UK, it was only 2%, just reflecting what was there in the trial. So therefore, all these clinical trials should reflect the population they do it. Also, we need to start accepting that the early onset type 2 diabetes is actually normal as an Indian subgroup. And therefore, the approaches that we take in this population needs to be different. So coming back to the case where I started, we measured the C-peptide, and I'm going to show you about how we interpret type 2 diabetes. First is the diagnosis should be less than 40 years. Could be type 2 diabetes, but the chances of type 1 diabetes and MODY are much higher. Could it be type 1 diabetes or MODY? Can be overweight and have type 1 diabetes. Specialist tests are available. And early onset type 2 diabetes is extremely high risk state because these patients. So in terms of diagnosis of type 2 diabetes in young adults, there is no test that's 100% accurately diagnosed diabetes. Age and body mass index are the two factors most likely to influence diabetes diagnosis, especially type 2 diabetes. Age and BMI are increasingly becoming poor at discriminating the diabetes subtypes. So this is a chart that actually I try to put this concept of textbook versus real life as to what we see. So the two factors that are driving the diabetes is one is increasing age. We know as we get all older, we get fatter, our pancreas start getting weaker, and we develop diabetes. There have been, I've seen papers from India showing that 60% of the population of Delhi above the age of 65 has diabetes. So age is an important factor. The second one is the BMI. As we all get fatter, the risk of developing diabetes increases. Typically up there is type 2 diabetes, occurring in populations with increasing BMI and increasing age. The type 1 diabetes, as it is classically described, and we have learned it from the textbook, is a disease of thin people at a young age. But now what we are really seeing is that type 1 diabetes even presenting at an older age. We are seeing in 40s, 50s, or even 60s presenting with type 1 diabetes, and some of it could be type 3C diabetes, but we are seeing an increasing prevalence of type 1 diabetes. Similarly, type 2 diabetes, as in my case in the 20s and 30s, we are seeing in obese and even in non-obese individuals who are developing type 2 diabetes. So we need to start considering two things. One is type 2 diabetes in lean people, which is not type 1 diabetes, and this is something of a challenge. And the second is the young onset type 2 diabetes occurring in obese individuals. So why is the classification hard and therefore requires more specialist input? So we've got a small pool of type 1 diabetes, a large pool of type 2 diabetes, and we've got the others. But what we're now seeing is all of them coming together, and a lot of other factors are affecting. So you've got adult onset type 1 diabetes, preserved insulin secretion in type 1 diabetes, therefore it behaves like type 2 diabetes, and the patients don't develop DKA. Then you have got type 2 diabetes in lean people, which can be confused with type 1 diabetes. Then you have got ketosis-prone type 2 diabetes. This is what we saw a lot during the COVID pandemic, where the prevalence of DKA in our patients with type 2 diabetes was increased by nearly 5-fold. Then you have got young onset type 2 diabetes. And then there are factors like ethnicity, genes coming into play. So what is becoming more and more important now is to have a better classification of diabetes and a specialist input at the time of diagnosis. The main factors helping to differentiate between type 1 and type 2 still remain mostly the same: younger age, lower BMI, unintentional weight loss, ketoacidosis, glucose greater than 20 or 360, ketosis without acidosis, asthmatic symptoms, family history of autoimmune disease are weak discriminators. I've talked about islet cell antibodies, and these are kind of recommended. Now, this is a flow chart that has been developed by ADA-EST and was published in Diabetologia. And this basically flow chart helps us to look and classify, I'm trying to see whether I can, how we proceed. So you have got adults with suspected type 1 diabetes. You can test for the islet cell antibodies. If islet cell antibodies are positive, then it is probably type 1 diabetes. If the islet cell antibodies are negative, which can happen in 5 to 10% of people with type 1 diabetes, you look at age. Whether the age is less than 35 years or greater than 35 years. If the age is less than 35 years, you look for any other features of monogenic diabetes like MODY, mitochondrial diabetes, and the others. If it is no, then you start looking for any features of type 2 diabetes like strong family history, increased BMI. If there are features of monogenic diabetes, you test for C-peptide. If the test for C-peptide is greater than 200, this is the measurement that is used, then you look for genetic testing for monogenic diabetes. If it is less than 200, then you go down the type 1 diabetes route. If there are no features for type 1 diabetes, type 2 diabetes, then you look for, then you go down the route of type 1 diabetes. If the features of type 2 diabetes at the age is greater than 10, and if you're unclear of the classification, make a clinical decision as to how the person with diabetes should be treated. Consider C-peptide test at the time or after 3 years. If it is less than 200, then it is type 1 diabetes. If it is between 200 to 600, and now they're talking about it being 800, then it is indeterminate. Now, this is a kind of a tool that I use in my clinical practice to try and guide me through the patients. All our patients get a C-peptide, get an insulin antibodies, and then if we think that they've got the features suggestive of monogenic diabetes, then we check for genetic testing for MODY. Now, when you're looking for C-peptide, there are certain important factors that the best. One thing you've got to remember is C-peptide all depends upon the glucose levels. So if the glucose levels are high, the C-peptide can be high. If the glucose levels are low, the C-peptide can be low. So the measurements usually should be done within 5 hours of eating is recommended. Again, whenever you measure C-peptide, make sure you measure the blood glucose levels. So if somebody is having a hyper blood glucose level of 3.9, then the C-peptide levels will be low and your interpretation will be wrong. So therefore, it's very important to measure the glucose concurrently. Persistent C-peptide levels of greater than 600 or 800 according to SEM suggests type 2 diabetes. By following this thing, reclassification of diabetes happens in nearly 11% of the population. Urinary C-peptide was recommended, but currently we are not using it. We are using a blood or a serum C-peptide in terms of diagnosis. As I mentioned to you about genetic testing for neonatal diabetes, monogenic diabetes should be considered in those with one or more of the following features: age at the diagnosis less than 35 years, HbA1c less than 58, one parent with diabetes and features of specific monogenic causes, be it renal cysts, partial lipodystrophy, maternal inherited deafness, severe insulin resistance in the absence of obesity, and you have got the MODY probability calculator, which if you Google, it's available. It's a fantastic tool where you can put in all the features and it gives you the risk of MODY. While I've talked a lot about type 1, type 2, and various types of diabetes, there is another question that we need to ask ourselves. Once type 2 diabetes, is all type 2 diabetes same, or are the features different? And this was a paper that was published in Lancet Diabetes and Endocrinology a few years ago, which basically tried to classify type 2 or all diabetes into 5 types. You must have seen, and this was mainly based on a database, and although there could be some questions as to how good this paper was based on the Swedish data, but they started looking at features of type 2 diabetes in a different context and not putting everybody in what I call the one bucket. And there was this another paper coming from Professor Mohan's group, which looked at it in a South Asian context, and they also came up with very interesting findings, and they did a much more deeper analysis depending on the age of diagnosis, BMI, waist circumferences, glycolated hemoglobin, triglyceride, HDL cholesterol, and C-peptide fasting levels and stimulated. And they identified 4 clusters. So I think now the time has come where we look at diabetes not as a single entity, but look into a deeper way. This is the only way we can give precision treatment to our patients and not start putting them all on what I can call SGLT2 inhibitors. So, Mr. Chairman, again, thank you very much. So in summary, I would say diabetes has genetic basis, and in coming years, our understanding has improved and continuing to get better. Diagnosing diabetes correctly will help us to target treatments and provide better care to our patients. Measuring genetic mutations in C-peptide will help us in the classification along with new tools that are being developed and the setting, glucotoxicity, the whole thing, including complication, is going to be an interesting area. Thank you.
Thank you, Wasim, Dr. Wasim. You have made it. Anybody, any doubt or any comment?
Yeah, so I think I should congratulate you for the excellent presentation. You brought out many important aspects about diabetes as we see it in our country, and I mean particularly with reference to the South Asian population that you deal with in Birmingham. So what we have been seeing, as you rightly pointed out, we see a lot of young diabetics, I mean younger individuals developing diabetes and who do not exactly fit into either of the two types of diabetes. I mean, either type 1 or type 2, and one of the classifications. And towards this end, I found that the WHO modified the classification in 2017, and they put this big bucket of unclassified diabetes. So many of our patients, actually younger patients, fall into that category where they don't have typical features of type 1 diabetes. They don't present with ketoacidosis, but they have significantly high glucose levels. They require insulin right from the time of diagnosis of diabetes. They are not managed with, they cannot be controlled with oral anti-diabetic medications, but they don't go into ketoacidosis. And they have a high risk of complications also. So this is a group which is very intriguing, and many times we do not find the exact label for them. So that's important. A couple of questions I just wanted to ask you, because you have been using the C-peptide assay. So what I wanted to ask you is that what you've said clearly that you would like to do it in the postprandial phase, post-meal values. Would you do stimulation tests with postprandial, because they describe some of these stimulation tests are described with glucagon stimulation, and would you use them, or would you just look at a mixed meal, or you would like to give a standardized meal or something like that?
No, thank you, Rakesh, for those excellent questions. So what has happened is that previously, whenever we used to check C-peptide, the whole concept was very complicated. So we used to do insulin along with that as well, which has to go in an ice and in a very noisy assay. The C-peptide assays were very noisy, so some people used to just do it in a fasting state. Now what we realized, along with lots of others, is that we need a kind of a practical interpretation of the test. So when the patient usually come into the clinics, they usually are in a fed state, unless you have to bring them back in a fasting state, as we do for glucose. Because we hardly check fasting glucose now, we rely on HbA1c. So in terms of the pragmatic way of interpreting C-peptide was to do it post-meal. The reason why we started checking the glucose was that was a kind of marker that would help us to interpret the C-peptide in a much better way. So when somebody is having a hypo, then their C-peptide levels will be low. It's similar to doing plasma and urine osmolality. So that again is a good marker for us to interpret it. Now the assays have got really better. So in the sense, once you do it, they are able to analyze and give you a much larger thing. Now for any of these kind of patients that you have described, in which the unclassified bucket, I'm not sure we tend to measure C-peptide on a regular basis at each of the clinic visits every 6 months or a year. And that gives us a kind of a graph as to what is happening to the C-peptide levels. And that is, again, is a much better measure in terms of trying to interpret the result. A single C-peptide can go this way or that way, and sometimes it's confusing. Because even if you've got somebody, say, with type 1 diabetes, if they are in a honeymoon phase with some beta cells left, so C-peptide will be high. So therefore, it's not the single, but it's the serial measurements that helps us in diagnosis.
One quick question is, would you like, could you measure the insulin resistance also? I mean, is there any calculation for doing that with the C-peptide?
No, currently, I think the insulin resistance, we tend to do it in some of patients, HOMA, but that's again quite a detailed test. Some labs like Oxford have developed their own protocols. We've got our own protocols. We do it in some of the patients, especially after they have, say, had a pancreatic transplant or a simultaneous kidney pancreas transplant, and if they put on weight and develop diabetes, whether it's type 1 or type 2. But using it in clinical setting is a bit of work. But I think we should be able to get onto there. One of my main points here, and this is where I feel it is very important for us to understand, is as we understand that these patients are complicated. So the ones that we get into real difficulty with is not, sometimes I cannot classify it or anyone else can classify it. But some of these patients actually present to the GPs or family care physician. And again, I see it in India because, I see a lot of patients here. These patients first go to, not a diabetologist or endocrinologist. And because most people think that, they don't have ketoacidosis, so this is all type 2 diabetes. And then they started on metformin. So there's one patient I remember very clearly in the UK. So there was a 27-year-old boy of Asian heritage. He was South Indian. His BMI was about 27, 26. He went to the GP. The GP said, check the ketones. There were no ketones. Started the patient on metformin. The patient went back. The glucose was still elevated after 3 months. Came to the doctor, and the doctor said, all this carbohydrate is the problem for you. So you stop the carbohydrate, go on what they call a keto diet, and started the patient on SGLT2 inhibitors. And within a week, he presented to the hospital in diabetic ketoacidosis with a pH of 6.9. We struggled to bring him back, and when we checked his antibodies and islet cell, they were positive. So he basically had something like LADA or latent autoimmune type 1 diabetes. And this is where the concern is that in young people, I'm not sure we're going to miss out, but especially I'm really concerned about the way we are dishing out SGLT2 inhibitors. Every time you go in, every person on the world will be on an SGLT2 inhibitor, I think. They've got a heart failure, renal failure, protects you. And this is a bit of a concern, that especially with diabetes, you've got to get it right. Because as you know, dapagliflozin has been withdrawn globally because of the risk of decay in type 1 diabetes. So therefore, if any of these patients are misclassified and the drugs are used, then we will end up harming the patients more.
Yeah, Darshan.
Nice talk, Asim. It's very interesting. C-peptide as a molecule, is it limited only for a diagnostic tool, or does it have any role in monitoring disease progression, predicting complications?
That's an excellent question, Shyam. I think C-peptide is a very important measure. So even in patients who have got type 1 diabetes, the amount of C-peptide level actually indicates the amount of control. So if you have got type 1 diabetes, but you've got about 4 or 5 beta cells working on you, producing C-peptide, then the risk of hypoglycemia or severe hypoglycemia, I'm not talking about ordinary, severe hypoglycemia is much less. What they call time in target range is much better. So even in patients who are able to produce a little amount of C-peptide, the prognosis is actually much better, even in people with type 1 diabetes. So again, it is a marker for not only diagnosis, but also predicting the progression of the disease.
Anybody? I thank Dr. Wasim for making the C-peptide, the importance of C-peptide. And we have a big clap for the speaker. Now I request, Dr. Rakesh Sahai to come out to the dais to speak about sitagliptin and DAPA.
Good evening to you. Thank you for being here today. And I think we had a wonderful presentation on a very important aspect about diabetes, about a type of diabetes that we see very commonly, these unclassified types of diabetes, where we need to actually look further beyond what we commonly see in our patients with type 2 diabetes. We see type 2 diabetes very commonly, and there are a large number of these patients who need to be further evaluated, and I think Dr. Wasim Hanif has really brought out the important aspects about this these types of diabetes, which are very common in our country. And so I thank him for that. I'll be discussing a little about, quickly I'll be going through some of the aspects about the metabolic derangements in Indian patients with type 2 diabetes, and bring out the importance of the SGLT2 DPP4 combination in our routine clinical practice. For the information of Dr. Wasim Hanif, unlike in most other countries in the world, SGLT2 and DPP4 become generic in our country, and we see unique combinations. We have a Sita-DAPA combination, which you'll not see for many years down the line. I mean, considering the fact that both of them are having patent in many countries. So we have this unique combination. So I'll just speak a little about this. We don't have too much data on this combination as such, but we have data about individual molecules. So I'll just quickly go through some of these aspects. Yeah. So what I'll try to do is I'll quickly look at this different aspects of type 2 diabetes, the need for combination therapy in type 2 diabetes, discuss some aspects about the metabolic derangements in type 2 diabetes, then discuss about the role of these two molecules, that is the SGLT2 inhibitors and the DPP4 inhibitors, and finally bring out the synergy of these two molecules and how they work synergistically in terms of managing people with diabetes. So Dr. Wasim has highlighted the importance of measuring insulin, C-peptide, and all these aspects, which are very important, because we know, if you look at the natural history of diabetes, we see that much before the onset of diabetes itself, if you are measuring insulin resistance, you would find that insulin resistance is the first abnormality which is present much before the onset of diabetes, and during that period there is significant hyperinsulinemia, and that ultimately presents in many different forms, and once the beta cell starts failing, then you start developing diabetes, and that's what happens in people with diabetes. So there's a long phase of pre-diabetes, or even a long phase of insulin resistance, when the person has got can present with cardiovascular disease, can present with dyslipidemia, can present with lipid abnormalities and all that. So if you look at the present status of diabetes, the present prevalence of diabetes, we all know that India has a huge burden, and if you look at the worldwide figures, the WHO, the IDF Atlas of the 10th edition of that, which was released last year, shows that 1 out of 7 adults with diabetes is from India. And the TIDE study has shown that a large percentage of people with type 2 diabetes have a suboptimal control. So there's a need for bringing these people who are at significant risk of complications at their target HbA1c, so as to prevent this problem. And as you can see, this is the ICMR INDIAB data, which shows that only 36% of the population with diabetes in the country is achieving good glycemic control, whereas most of the remaining people are above the target, and the states with the highest HbA1c levels are probably Punjab, Bihar, Chandigarh, Haryana and Karnataka. So these are that is the state of affairs in our country as on today, and we see that most of our patients are at risk of complications, and we also know the fact that we have a type of diabetes which is different from the Western population. Dr. Hanif was actually bringing out some of these aspects, that we have a early onset of diabetes. As we know, we have diabetes occurring a decade earlier than the Western population, and then we have faster progression from pre-diabetes to diabetes. We said that there is these stages of diabetes, that is, somebody remains pre-diabetic, then becomes diabetic, then develops complications. So what we see is that in our population we have very rapid progression from pre-diabetes to diabetes, and we have a high level of insulin resistance, abdominal obesity being the major factor, because of which there is increased inflammatory markers, lower adiponectin levels, and we have a faster deterioration of the beta cell function. All these have been shown in different studies across the globe, and particularly from comparing different populations, these have shown the South Asian population with the UK population, the South Asian population in the US. These studies have clearly shown that we have these features which are typical of our population. Now, Dr. Wasim has just shown us about the clustering of type 2 diabetes. Apart from the fact that you have a difficulty in classifying people with younger people with diabetes, whether they are type 1 diabetes or type 2 diabetes, whether they have other secondary types of diabetes, we always have that sort of dilemma. But beyond that, even amongst the patients who are otherwise accepted to be type 2 diabetes, we know that there is a lot of heterogeneity, and that was studied in the Swedish cohort. And then, as he was also speaking about this paper, he was showing us this paper from Dr. Mohan's group, where they have actually retrospectively looked at all the data they have from their clinic, and also from some of the ICMR INDIAB data. So this was they looked at some of these parameters, and they classified, they put these patients into 4 clusters. So these are not actually defined clinically, but these are clusters which are identified based on certain parameters, 5 or 6 parameters, 8 or 10 parameters that were taken. The original Swedish clusters took about 4 or 5 parameters, and they looked at this, and they said we have, unlike the 6 or 5 clusters shown there, we had slightly different, the Indian population had a slightly different sort of characteristics in terms of, 2 of them being similar, like mild age-related diabetes was also seen in our population. And but we saw that there was this severe insulin deficient diabetes, which was very common. Combined insulin resistant and insulin deficient diabetes was common. This was something which was unique. This was not seen in the Swedish clusters. And we have the insulin-resistant obese diabetes, which was also seen in the Swedish clusters. But I think some of the ones which were very characteristic of the Indian population was the combined insulin resistance and insulin deficiency. That is, we have both the components are quite exaggerated in our population. That is, the insulin resistance is also quite significant, and at the same time there is a significant insulin deficiency also. So that was something which was unique. Uniquely found in the Indian population, and I think we need further studies to look at that. Probably prospectively we need to look at it, and that will probably give us more information on that. So we have a progressive nature of type 2 diabetes. Suboptimal glycemic control is very common, and the fact that we know that there are different factors contributing to the pathogenesis of diabetes, and because of this we can say that one single drug may not always work in terms of keeping the patient under glycemic control, and therefore we need a combination of more and more agents, and that's the reason why we have these different combinations available, because patients with diabetes require multiple medications, and if you have a fixed dose combination, that works very well, because in terms of improving the compliance to therapy. So this is a famous slide which shows the 8 different defects which are present in people with which can contribute towards hyperglycemia in people with diabetes. This was proposed by DiFronzo, and as we can see that there are 8 different factors contributing to the pathogenesis of diabetes, and today we have medications which are correcting all these abnormalities. So you have different medications which are covering which are acting at different points to overcome these 8 defects. And so one of the important ones is the incretin defect, which got identified maybe about 2 or 3 decades back. We started having therapies for that, and then now we have the SGLT2 inhibitors, which look at which typically address the increase in glucose reabsorption from the kidneys, and then we have different therapies. If you look at the DPP-4 inhibitors, they probably address 6 out of these 8 defects, and you have the SGLT2 inhibitors addressing the other one, which is in terms of the increased glucose reabsorption from the kidney. And probably if you use a combination of these 2 agents, what we're trying to say, what is said is that probably you are addressing most of the defects. So that way you are able to sort of get a better glycemic response with a combination of these 2 molecules. So that's what I'm trying to show in the subsequent part of my presentation. So if you look at the incretin defect, this is quite clearly shown that people with diabetes have a significant defect in the GLP-1 production. And as you look at healthy individuals versus people with pre-diabetes versus people with diabetes, you find that there's a incremental decline in the GLP-1 secretion, which is very important in terms of maintaining the insulin secretion. And I would say that to address this defect, we have the GLP-1 analogs and the DPP-4 inhibitors. DPP-4 inhibitors have become very popular molecules because of the fact that they are orally used, and cost effectiveness has increased with the availability of with the fact that some of them have gone off patent. Sitagliptin has gone off patent, and vildagliptin is also off patent. So we have these available at a more economical price, and they are used, while we have the other ones also available in our country. Apart from we have 6 different gliptins available today. Now, if you look at the SGLT2 inhibitors, they are particularly blocking the action of blocking the reabsorption of glucose through the SGLT2 channel, which is present primarily in the proximal tubule. 90% of the glucose reabsorption in the primary proximal convoluted tubule is happening through that, and this results in about 180 milligrams of glucose. 180 grams of glucose being lost in the urine every day. And this leads to a net loss of glucose in urine, and with the use of SGLT2 inhibitors. But in the absence of SGLT2 inhibitors, what happens is that a normal person would reabsorb all this glucose, and in fact it is said that with people with diabetes would have a slightly higher glucose filtration through the proximal convoluted tubule, and that also gets reabsorbed, and the net glucose loss is reduced, and that this factor could be playing an important contribution towards hyperglycemia. And using SGLT2 inhibitor, as you can see here, reduces the glucose absorption and leads to glucose excretion in the urine, and that also has other benefits in terms of causing rectifying the tuberoglomerular feedback and providing several benefits in terms of the renal sort of damage which is slowed down. So I think what we are saying is that just like we find that the GLP-1 and GLP-1 secretion is lower in patients with diabetes, the DPP-4 activity is slightly higher. Similarly, the SGLT2 activity has been shown in some studies to be higher in people with diabetes, and thereby they probably contribute to the higher reabsorption of glucose into from the proximal convoluted tubule. Now, if you look at the newer class of drugs, as we are speaking of, Dr. Wasim was also mentioning about the importance of SGLT2 inhibitors, which has been addressed in the recent guidelines, because we are now, with the availability of information from the cardiovascular outcome trials, what we are seeing today is that our approach is changing from being glucose-centric to patient-centric, looking at the cardiovascular benefits and renal benefits of any molecule that we are looking at, and that's the reason why we have sort of changed our approach, and this is what the current guidelines say. The ADA EASD guideline speaks about this. This is what was revised in, say, I would say in 2016 or so. It was revised, and then following the availability of information from the EMPA-REG trial, and then subsequently all the other cardiovascular outcome trials have actually changed the approach towards management of diabetes, and for the information of all the audience over here, I would like to say that the first line remains metformin, but what has happened in the last 2-3 years is that people are also speaking about, the European Society of Cardiology, and followed by the EASD and the ADA have also spoken about having the SGLT2 inhibitors or the GLP-1 analogs as first-line therapy in those where there is a compelling indication, just like, people who have got diabetes with a cardiovascular disease, established ASCVD, or those who have got a high risk for heart failure, and those who have got CKD. In all these populations, there is a benefit of using SGLT2 inhibitors and or GLP-1 analogs, and so they can be considered in some patients even before metformin. That is what the current understanding is. But otherwise, in most of other patients, we would use metformin as the first line agent. Then once metformin once we are not able to have adequate glycemic control with metformin, then you would look at as a second line agent, you would triage patients based on the presence of ASCVD or renal cardiovascular disease or CKD. If they have this, then again you look at these two classes of drugs. But in the absence of this, you would look at look at other factors, like whether hypoglycemia is a major issue or whether weight is a major issue for this patient. And based on that, you would categorize the use of drugs. You would choose drugs which cause less of hypoglycemia, like DPP-4 inhibitors cause less of hypoglycemia. SGLT2 inhibitors also do not cause hypoglycemia. The additional advantage that the SGLT2 inhibitors have is that they can cause weight reduction to the tune of about 2 to 3 kgs in patients with diabetes. And the other factor was the consideration of cost and access to medications. So that has actually changed a little bit in our country, in the sense with the availability of the generic forms of DPP-4 inhibitors and even SGLT2 inhibitors, particularly dapagliflozin is available in a generic form. So that has made these two classes of drugs easily accessible, while the GLP-1 analogs still remain beyond the reach of many of our patients. So if you have ASCVD or heart failure or CKD is present, Then the SGLT2 inhibitors with proven cardiovascular benefits like the empagliflozin or dapagliflozin and even Cana are the preferred agents. GLP-1 receptor agonists with proven CV benefits, that is liraglutide, semaglutide are the ones that are, and even dulaglutide are the ones which are preferred. So choosing the second and third line agent therefore depends a lot on the presence of these factors, that is atherosclerotic cardiovascular disease, heart failure or CKD. And in the absence of these, we are looking at factors like hypoglycemia, weight, and the availability of and accessibility to these drugs. Now, just a quick mention about the cardiovascular outcome trials with the DPP-4 inhibitors. As we can see, we had cardiovascular outcome trials with most of the DPP-4 inhibitors, and what we have understood from this is that these molecules are safe from the cardiovascular point of view, but they do not have any additional benefit in terms of reducing the cardiovascular events. But they are safe in terms of people who have cardiovascular disease, who have existing cardiovascular disease, or have multiple risk factors for cardiovascular disease. In such patients, they can be used safely without any problem. And across the board, all the trials, if you look at this, has all the trials for glucose lowering agents. And what we see is that when you look at some of the trials like the EMPA-REG trial, that was the one which showed a significant cardiovascular benefit and benefit in terms of reduction in the 3-point MACE and also reduction in the cardiovascular, all cause mortality and cardiovascular mortality. And then we have other data from other trials like the SUSTAIN-6 and LEADER trial, which are the GLP-1 analogs, liraglutide and semaglutide. They have also shown the benefit in terms of the 3-point MACE, and clearly we have changed our understanding about the use of these agents with the availability, with the results from these cardiovascular outcome trials. So I'll not go into further details of this, but what I would like to highlight is that with the use of SGLT2 inhibitors, as we can see that with glucose loss in the urine, there is benefit in terms of the weight. There's some benefit in terms of reduction in the blood pressure, some amount of benefit in terms of reduction in hyperuricemia, and all these benefits translate into significant cardiovascular benefits, as was seen from the cardiovascular outcome trials of these agents. Now, quickly, I'll now move on to discuss a little about the benefits of using these two molecules, that is the SGLT2 inhibitors and DPP-4 inhibitors, how they fare in terms of a combination of these two agents in terms of the benefits it provides. So, what we have clearly seen from the outcome trials of the SGLT2 inhibitors is that there was a clear benefit in terms of the cardiovascular benefits and also the renal benefits, which is shown in the CREDENCE trial and the DAPA-CKD trial, and showing that there is a benefit in terms of improvement in these parameters. So, having looked at that, I'll not go into too many details of this, but I would like to say that in summary, I would say that with the main, if you look at the main outcomes of the trials with DAPA and EMPA, in the heart failure trials, you've seen that there is a reduction in the hospitalization for heart failure and cardiovascular deaths by 26%, reduction in cardiovascular deaths by 14%, reduction in hospitalization for heart failure alone. That's the one which has shown the maximum benefit with the SGLT2 inhibitors, 31%. Reduction in renal events has also been shown in the DAPA-CKD trial and the DAPA-CKD and the EMPA kidney trial, 38% reduction in the renal events. So across the range of ejection fraction, different ejection fractions, that is those with heart failure with preserved ejection fraction and also those with reduced ejection fraction, you find that there is a significant benefit with the use of these agents. And even in patients who are on all other therapies that are required for the management of this condition, over and above the benefits that are produced by ACE inhibitors, ARBs and RNAs, you find that there is this benefit comes up with the use of these the SGLT2 inhibitors. So having looked at that, let me just now show you why we should combine these drugs. What is the benefit of combining these two classes of drugs? So what we have seen is that when you combine these two classes of drugs, it stands to reason, and it's a rational combination because the drugs complement each other's actions. The benefit number one is that they complement each other's action. Benefit number two is that they influence multiple targets to optimize the glycemic control. Benefit number three is that they preserve the beta cell function to be effective over a longer period of use. And the fact that they don't need a dose titration, unlike the SUs. When you used to use metformin or SU, you needed to titrate the dose based on the glycemic response that you get. But with these two classes of drugs, you don't need any dose titration, and you don't need any sort of adjustment in the dosing. So you have a fixed dose of both these molecules, and that works well. So if you're using it, you use a single, a fixed dose, which works well for this combination. So if you look at a network meta-analysis of the A1C lowering in patients who are on a background of metformin, you see that you see the best benefits with subcutaneous semaglutide followed by oral semaglutide. That's more than 1.33, more than 1% reduction in HbA1c. Insulin, surprisingly, is in this analysis is showing close to 0.9%, but insulin has the best benefits because you can titrate the insulin to whatever dose required. But essentially what this shows is that if you look at the molecules like the SGLT2 inhibitors, they're showing beyond 0.5%, 0.5 to 1%, in the range of 0.5 to 1%, they are there. And you can see that the DPP4 inhibitors are also in that range. And together they bring down the HbA1c by more than 1%. So that's the essential message from that. And this is giving a summary of all the, all those parameters that we always look at, the 6 parameters that were looked at when you're looking at different agents, but I'm not going to spend much time on this. What I would like to highlight is that there is similar glycemic efficacy between DPP4 inhibitors and sulfonylureas, significantly lower incidence of weight gain and hypoglycemic episodes with DPP4 inhibitors as compared to sulfonylureas, no specific cardiovascular benefits either with DPP4 inhibitors or the SUs, and the cost of DPP4 has come down significantly. At least the cost of sitagliptin and vildagliptin has come down significantly, while linagliptin still remains at a higher price. But what we are seeing is that we have this these benefits with the use of SGLT2 inhibitors and the DPP4 inhibitors. Now, if you look at SGLT2 inhibitors and look at their comparison with the SUs, again you find similar efficacy, much lower weight gain because you can get weight loss with SGLT2 inhibitors, and there is a specific CVD and renal benefits, as you can see from as we have evidence from all the cardiovascular outcome trials. And the cost of SGLT2 inhibitors, particularly dapagliflozin, has also come down significantly with the availability of these generic brands of dapagliflozin. So what we are saying is that clearly there is a benefit of combining these two, these two agents which have a modest action, 0.6 to 0.8% reduction in HbA1c. Combination brings down the HbA1c by more than 1%, and as I was mentioning earlier, that it addresses most of the defects. So you can say that almost 6 out of the 8 defects are addressed, or maybe the 7 out of the 8 defects are addressed by the use of this combination, and hence you are able to effectively bring down the blood glucose levels. And this is seen in clinical trial data also. We have clinical trial data of the combination with the combination of Empalina, which has shown significant benefits. And in fact, in that combination, we find that the side effects of SGLT2 inhibitors in terms of urinary infection and the genitourinary infections has been lower with the use of the combination, which could be either because of the greater reduction in HbA1c, or it could be because of the DPP4 inhibition in the microorganisms. So these are the postulated mechanisms suggested, but there is a benefit that is what is seen with the use of this combination. While we don't have a lot of data with DAPA-CETA, there's an ongoing study which is looking at the real-world study, looking at the benefits of this combination, and also in terms of the glycemic benefits and also the other benefits of this combination. So we need to await results of that, while we know that, there is a complementary action of DPP-4 inhibitors and SGLT2 inhibitors, which I have already, spoken about. But I would just like to highlight here that what happens is that the SGLT2 inhibitors lead to an increase in the glucagon secretion, which is suppressed by the DPP-4 inhibitor. So they complement with each other in terms of this action also. So the combination therapy addresses multiple pathways, multiple metabolic abnormalities. It probably delays the natural progression of diabetes, can be used in patients across the spectrum of diabetes, and it would help enable more patients to reach glycemic goals with a lower risk of hypoglycemia, lower weight gain, and also providing the cardiovascular benefits. So those are the benefits of this combination of SGLT2 inhibitor with SGLT2 inhibitor with the DPP-4 inhibitor. Particularly here we are speaking about sitagliptin and dapagliflozin. And so I think that is quite clear. And when you're looking at selecting therapy for patients with type 2 diabetes, and if you look at two important factors, the evidence that is available and their mechanism of action, what we can see is that as you look at the evidence from CVOTs, you are more in favor of using SGLT2 inhibitors in people with ASCVD, CKD or heart failure. And when you're looking at the proportion of patients who can be on therapies like DPP-4 inhibitors because of their easy availability and the fact that they would benefit a significant proportion of patients with diabetes, the combination of this remains a useful combination. So I would probably conclude with one or two slides. This one saying that this is a rational combination which addresses 6 out of 8 pathophysiological defects which are contributing to the development of hyperglycemia and diabetes. And there's proven safety and efficacy of both the drugs, additional benefit in terms of the cardiovascular and renal protection that is provided, and the fact that the pharmacokinetics are appropriate with once daily dosing of both the molecules, and the availability of CVOT data. And however, this should not be used in some patients, like patients with who are having LADA, or Dr. Wasim has rightly pointed out that the widespread use of this dapagliflozin may sometimes be a issue, particularly when you're using it in people with LADA or those who have unclassified diabetes, those who are actually type 1 diabetes. He also gave us the example of the 27-year-old South Asian who presented with ketoacidosis because he was started on SGLT2 inhibitor when he was not controlled with metformin alone. So these are things which have to be kept in mind. And for the DPP-4 inhibitors, you have to avoid it in patients with acute pancreatitis and those who have got frequent genital and urinary tract infections. You may have to avoid that. So these are situations where and those with any prior history of DKA. So I think these are 3 or 4 situations which we should clearly keep it in mind. Any patient in a severely catabolic state, that is somebody who's losing weight, very high sugars, who is admitted to the hospital, in such situations never use a SGLT2 inhibitor, and avoid DPP-4 inhibitors in patients who have got prior history of pancreatitis, or a person with fibrocalcific pancreatic diabetes also. In all these situations, avoid the use of DPP-4 inhibitors. So with that, I'll conclude with this slide saying that we need to look beyond HbA1c lowering and look at the cardiovascular renal benefits provided by and choose agents based on the benefits that they provide. While metformin remains the first line therapy, but we need to look at all the other classes of drugs that are available, and some of our patients we may also look at using drugs like the SGLT2 inhibitors and GLP-1 analogs even ahead of metformin, particularly when there's intolerance to metformin, or when they are mildly hyperglycemic and you require a single agent. You may choose agents like the SGLT2 inhibitors in such scenario. So I think this combination remains a very useful combination in the management of diabetes, and it provides not only glycemic benefit but even provides the extra glycemic benefits that we are looking at. So with that, I'll conclude, and thank you all for the patient hearing.
Thank you. Thank you, Rakesh. Any clarification or? Mike,
Yeah. So if you look at the data about canagliflozin and dapagliflozin, we had some studies showing that there was a increase in peripheral amputations in lower limb amputations, particularly with the use of these agents. So those with peripheral vascular disease are still a group, while larger studies have not shown that to be an important signal. Like, when you look at the larger cardiovascular outcome trials, they did not show this increase in amputations, but still, I think when there is a presence of peripheral vascular disease, it would be prudent to avoid the use of SGLT2 inhibitors. Dr. Wasim, would you like to add to this?
No, I think you're absolutely right. I think the SNPC says that you should not be using, especially if there is active foot ulceration, these drugs need to be avoided. Can I have a question? Thank you, Rajesh. I think that was, Rakesh, that was a very comprehensive talk, just to go through all this thing. Now, one of the things which I always wanted to ask is, there had been some publication, I don't know whether from Avdesh, A.K. Singh and the others, which have shown a better efficacy and response of DPP-4 inhibitors in an Indian population when compared to what we get in the clinical trials. Any opinion, thoughts on that?
Yeah. So I think this all started off with the data on vildagliptin, which was 2005. We had one study which looked at vildagliptin in 4 countries: India, South Korea, and I think US and other. Therefore, I think 2 or 3 different populations just studied, and in that particular study, they found that there was a slightly better glycemic reduction in Indian population, and that led to actually further analysis of data from all the other studies, and it is said that and that has shown that there is a slightly better reduction in HbA1c with the use of DPP-4 inhibitors. Even for the GLP-1 analogs, that sort of difference has been shown, and Dr. Avdesh has recently published one sort of analysis. I think it was a meta-analysis where he looked at different studies and tried to look at the dissecting out the Indian component of that, and he showed that difference. What is suggested is that because of the fact that we tend to have a faster decline in the GLP-1 secretion in Indian population, it is probably that these agents which are working through the incretin pathway have a better response in Indian patients. That's what is suggested. I look forward to hearing from you also what you would.
I think the reason I raised that question is because one of the things that we did our guidelines from the South Asian Health Foundation UK, basically trying to see what should be the first line agent. Now, although we again have been using metformin for a very long time, I think with metformin, I think from the diabetes prevention program and the other studies, especially in a vegetarian population, we are seeing a lot of vitamin B12 deficiency, which again is not picked up. They present with either peripheral neuropathy or anemia. So one of the questions that has been asked is metformin the first line agent in this population? And secondly, because especially in a younger cohort, less than 40 years, when you're trying to treat them aggressively, the question is whether we should be moving an SGLT2 inhibitor or even a combination of DPP-4 SGLT2 inhibitor as a first-line oral agent, followed by GLP-1 analogs or whatever, GLP-1 if it's obese. So these are some of the questions that we perhaps need to ask, and whether there's still a role for sulfonylureas, because from what you have shown is still sulfonylurea is a first-line agent. So I think these are the kind of things when we do the guidelines, instead of just following the ADASD guidelines, whether we need a more specific guideline from a South Asian cohort saying that we should perhaps start thinking whether metformin is not the be-all and end-all, and we need to start looking at other agents.
Yeah, as you're, as you're mentioning this, what I'm thinking is that we also need actually an analysis of the effect of metformin across different populations.
Yeah, absolutely.
Whether we have the same benefit as we see
Absolutely.
with metformin in other populations.
Yeah.
So that is something which needs to be studied. While we have been, studying the benefits of SGLT2 and DPP4, we need to actually analyze the benefit of metformin in our population as compared to other populations. And that would actually help us in understanding whether metformin should always be the first line or not, or whether we should look at other agents. Because when we were, thinking of, when we were bringing out the RSSDA guideline, and we were looking at adapting it from the IDF guideline, there was a lot of discussion on metformin, whether only metformin should be the first line, or whether we should also recommend sulfonylureas particularly in the lean and thin people with diabetes. So that was a lot of discussion there. But I think what we need to analyze is look at the benefits look at the glycemic effect of metformin across different studies with different populations.
I don't know, Dr. Basant Kumar is not here. But one of the things that we could suggest is, because the SAP guidelines which we published in diabetic medicine from UK, I think that also requires an update. So I was speaking to Kamlesh and the others to do it. But I think it will be good to get a kind of a global thing, basically focusing on the South Asian context and coming up with a more specific guidelines for this population. Because now out of the whatever million people with diabetes, nearly a third of them are from the Indian subcontinent. So I think we perhaps need a kind of a cross-collaborative global thing to come up with the guidelines and not just stick with the ADA-ESD.
Yeah. Thank you, Dr.
I have a query. Why the Westerners prefer combination drugs? In
What?
India,
Yeah, I think that's a very great question, and I think especially in the UK they hate combinations. There is no reason for that. I think it is probably historic. What has happened is the people who make the BNF or run the BNF, they were against the combination, especially if they have side effects or stuff like that. So there is no scientific basis for it. It is completely irrational, pill burden and everything. And every time a combination comes in, no, except cocodamol, which is the paracetamol and codeine, no other combination works in the UK. All these combinations are there, but they fall flat. I think it's just a mindset. No reason for that.
I think if there's no more questions, I think we'll conclude this session. We thank Dr. Rakesh, Professor Rakesh Sahai and Professor Wasim Hanif for their excellent talk, and thank you for all for coming. Thank you.